This video will demonstrate intermittent tube feeding for a patient with a nasogastric tube. Now the process is going to be very similar for a patient with an oral gastric tube or a PEG tube, but for demonstration purposes we are going to focus on intermittent tube feeding through a nasogastric tube. So the first thing I want to do before entering the room is I want to verify my physician's orders, make sure I have the proper tube feeding formula, make sure I have all the proper equipment, and I have verified all that information prior to entering the room. I also want to verify patient allergies, verify their weight, and making sure I do a good focused nasogastric tube assessment prior to initiating any type of feeding through it. So you can refer back to the NG tube assessment video for a full focused NG tube assessment. For time purposes and video purposes, we are going to skip that part and focus on one extra step of assessing an NG tube for proper placement and then administering an intermittent tube feed. So we want to make sure we get our bed to a workable position, good hand hygiene, put on good clean gloves, we've gathered our equipment, and we want to make sure our patient is elevated to at least 30 degrees, but preferably up to 45 degrees for a patient getting tube feed. So we have done our good focused gastrointestinal assessment. We've made sure our exit site is appropriate. We've checked for a chest x-ray or an abdominal x-ray to make sure that we are in the appropriate position. And now we're going to initiate feeding. So the first thing I want to do is check for gastric residual volume or gastric aspirate content to make sure again that we are in the stomach. So to do that, we are going to take our equipment here. And we have a 60 ml syringe with a plunger. We have a basin, and then we have our plunger basin as well. So I want to make sure I grasp and clamp the NG tube here before removing the blue port. This is going to prevent any gastric content from coming back up the tube. And we also want to make sure a towel is in place because if we fail to clamp this, it could be a little bit messy on our hands. So towel, protect the patient, make sure we're clamping the tube prior to removing the plunger. Remove the blue port. We are going to take our 60 ml syringe, connect it to our NG tube opening, and then we're going to release the clamp. From here, I am going to pull back on my plunger. And what I'm looking for here is for gastric content to be coming up the NG tube. That's going to confirm placement, knowing we have good gastric aspirate, making sure we're in the stomach there. While I'm doing this, I also want to check for gastric residual. So I will continue to pull back. And what a gastric residual volume is the amount of formula that is left over after the previous feeding. So we want to make sure we have good gastric emptying, good gastric and intestinal motility, make sure that the patient is tolerating everything okay. Again, refer back to that video to the abdominal distension, nausea, other symptoms of not tolerating. So I'm checking my gastric residual volume. And what I want to note here is that you're going to see some different numbers. What we want to make sure that we do is as we pull gastric residual volume back, we want to make sure we return it to the stomach. And what we're doing there is protecting the fluid and electrolyte balance of our patient. If we were to remove a lot of gastric content, a lot of residual volume, and not replace it in the stomach, we're going to throw that balance, that fluid electrolyte balance off, and it could have some negative consequences for our patient. Now we can return 200 to 500 mLs of gastric content back into the stomach. Now the reason we have such a varying range is it's going to depend on your institutional policy. The textbook says not to remove anything less than 500 mLs. Some institutions will say 200, 250. So you want to make sure you check your institutional policy and understand that the best evidence-based practice says anything less than 500, we are returning back into the stomach. So here I only have about 40 mLs of gastric residual volume left. So I'm going to make sure I return that to the stomach. And I'm going to go ahead and clamp. So we've confirmed placement, we've checked our gastric residual volume. Those are two things we want to document. So I want to make sure I write down that I had 40 mLs of residual volume left. Next, what I'm going to do is I'm going to draw up 30 mLs of water in my 60 ml syringe. And I'm going to go back to my NG tube here. I'm going to make sure I'm clamping, removing the blue port, and reinserting my syringe with 30 mLs of water. And I'm going to slowly flush that 30 mLs of water through the NG tube to clear the tube of any gastric content or precipitate that has come up when I was checking my residual volume and checking for placement. So I have flushed with 30 mLs of water. We have cleared out the tube. Go ahead and clamp one more time, again, preventing any spillage. And then what I'm going to do, I'm going to go ahead and plug this so I have two hands, is I want to take the plunger and separate it from my syringe at this point. So I'm going to get rid of the plunger, and I am going to connect to my NG tube the syringe. This gives me an open reservoir to put the tube feeding through. So we have checked placement, we have flushed. Anytime before any type of feeding you're initiating, you want to make sure you flush with that 30 mLs of water. We've checked our physician orders. This is one example of a intermittent tube feed that you may instill into a patient. This is another example. There's numerous examples out there from facility to facility. And we can also use a tube feed pump to give intermittent tube feeding, but we are going to do this by gravity here. So I have my syringe in place, checked placement, flushed my NG tube. All I'm going to do here is take my 1.2 calorie isosource HN, and I am going to pour into the syringe until I have it full. Now from here, I want to let gravity do its work. It is going to slowly infuse that tube feed through the NG tube. I never want to force it through. I never want to take the plunger and inject it more quickly because that's going to be very difficult for the patient to tolerate. So we're letting gravity do its work and drain the tube feeding one syringe at a time. So once that is emptied, I will pour 60 more mLs, let gravity infuse the tube feed through the NG tube into the stomach, and I'm going to do that until my ordered dose, my ordered amount of tube feed has been complete. So I will fill it one more time in my syringe, 60 mLs. You don't ever want to lift it above 18 inches above the entrance site. That is going to make it infuse too quickly, and it's going to be difficult for the patient to tolerate. So we keep it right about here, let it infuse naturally, slowly, so we're not causing any discomfort to the patient. One tip I'm going to mention just while I'm here is you don't really want to be looking down the tube. Keep in mind if the patient coughs, they get nauseous, any pressure that builds back up, you have the potential of feeding coming back up out the syringe. So you want to make sure you're holding it over the towel, keeping it clean, and making sure you're not looking over. And I mentioned that from experience, so keep that in mind when you're doing intermittent feeding. So I have given my full amount of tube feed. I'm going to go ahead and make sure I clamp, replace my port, kind of agitate your syringe, get it cleaned out a little bit, and then from your clean water, you're going to reconnect your plunger, and we are once again drawing up 30 mLs of fluid, 30 mLs of water. We're going to clamp our NG tube, remove our blue port, and at the end of each feeding, we're making sure we are flushing once again with 30 mLs of water, nice and slow, to clear everything from the NG tube and get it into the stomach. And I will clamp one more time, remove my syringe, connect my blue port, and I have now given my intermittent feeding amount to my patient here. Once we are done feeding, we want to make sure that we keep the patient elevated, again, at least 30 degrees. Ideally, we would like it to be 45 degrees, but at minimum 30 degrees. And we want to do this for 1 to 2 hours after initiating a feed. If we were to lay the patient supine right away, you have that potential risk for the tube feed and refluxing back and the potential for aspiration. So again, we want to minimize and prevent any potential complications for our patient. Other things we want to do, some other notes to keep an eye on. Anytime your patient's getting tube feeding, we are going to be doing strict I's and O's. So we want to make sure we're documenting the full amount that we administered, including the 60 mLs of water, the 30 before, the 30 after. So we're documenting that. We are keeping a close eye on their output, both bowel movements and urine, making sure that we are maintaining a good fluid balance with our patients receiving this type of feeding. We also want to monitor our daily weights every day. We're looking to make sure that the patient is not losing weight, that they are getting the right nutrition through that intermittent feeding. We want to review our labs, making sure our electrolytes are staying within normal limits, alerting the physician if anything becomes abnormal with our electrolytes. And we are going to make sure we're monitoring our blood glucose levels. Now, this is going to be done at minimum of 4 hours, but usually every 4 to 6 hours for patients receiving tube feeding. Again, they're NPO outside of getting this formula that we're giving them, so we want to make sure that we're maintaining that glucose level in a safe range. And if they are getting elevated glucose levels, we may need to get some medication on board to treat that. Making sure we're checking the gastric residual volume before every feeding, and we are returning up to 500 mLs of that residual volume to maintain that fluid and electrolyte balance. We are doing a good focused assessment confirming placement, making sure the patient is tolerating everything okay. We are making sure our exit site is appropriate, that we have that abdominal or that chest x-ray confirming placement. And we are making sure the patient's tolerating everything okay. So 1 to 2 hours, we keep them elevated, return to the room, do another assessment, making sure they're not nauseous, abdomen hasn't been distended, that they're tolerating everything okay, and then we can lower them back to a comfortable position. Following this procedure, we want to make sure we are documenting, again, our eyes and nose, documenting the procedure, the amount of water that we flushed with, and then documenting how the patient tolerated the feeding. We will lower the bed, side rail up, perform hand hygiene, remove your gloves, and that is the end of our intermittent tube feed procedure. One thing to make mention before we end that video is anytime you're using supplies such as the 60 ml syringe and your basin here, including your packaging, we want to make sure we are labeling this with our initials, our date, and our time that we first started using this equipment. This equipment is good for 24 hours. Anything longer than that, sitting in the patient's room, you have that risk for growth of microorganisms, infection risk. So making sure we are assessing and making sure that we are using this within that 24-hour time window. Now that concludes the intermittent tube feeding video.